Dr. Justine Welsh is an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. She is a child and adolescent psychiatrist as well as an addiction psychiatrist. She's founding director of the Emory Healthcare Addiction Services, and she's medical director of the Addiction Alliance of Georgia, a collaboration between Emory University and Hazelden Betty Ford Foundation. Before that, she established treatment programs for substance use disorders in adolescents and young adults, for which she won the Emory University Rising Star Award, or the Emory University Award as a Rising Star. Dr. Welsh's area of clinical and research focus is in the treatment and prevention of adolescent substance use disorders, as well as opioid use in young adults. Her programs provide medication for opioid use disorders for persons 14 years and older. She has been the recipient of grant funding from several national organizations, including an R01 and R21 from NIDA. And with that, please join me in welcoming Justine Welsh. Justine.
Thank you so much for having me here today. It's an honor for me to be speaking to this group, especially since some of the papers I'll be referencing come from members of this group, some of my colleagues, and even mentors. I appreciate the background. I'm a child, adolescent, and adult addiction psychiatrist. And today we're going to be talking about opioid use disorder in youth, but highlighting some of the barriers to care that are very specific to specialty addiction treatment. To date, studies have largely focused on low rates of national prescribing, but this will really highlight the need within our own specialty clinics to be improving care. And I'll largely be walking you through my journey with a recent R21 funded by NIDA on this topic. So please, very informal, put any questions you have in the chat, and we'll also be open to discussion at the end. So let's jump right in. Here are my current sources of income. I do want to highlight as we move on here, support from my R21, which was funded in 2018 by NIDA. And most of the original work I'll be discussing today is derived from that grant. So just a little background information here, and this is not meant to be comprehensive of the literature, but more to make a few key points. So I've selected some studies that really highlight the themes that we'll be moving through. One that we are likely familiar with is that youth have been impacted by the opioid overdose epidemic, which sounds a little intuitive, but I believe it's something that is too often overlooked. So for example, opioid-related emergency department admissions have been increasing, and we've seen a rising mortality in youth with deaths attributable to opioids, as well as many other adverse outcomes. Here you see the trajectory of overdose deaths in youth ages 15 to 24, which is data published by the CDC. Rates have been steadily increasing over time. There was this kind of dip in 2018, but then a dramatic increase since then, reaching to about 6,000 individuals in 2020 and even higher now. We know from extensive literature that MOUD, or medication for opioid use disorder, across the board has numerous benefits, including decreased mortality, improved treatment retention, decreased high-risk behaviors that result in health complications like hepatitis C, and increased rates of abstinence for those who receive it. But unfortunately, work from a previous presenter and past collaborator of mine, Dr. Scott Hadland, has demonstrated that in certain populations, less than 5% of adolescents and less than 30% of young adults receive MOUD within 3 months of an OUD or opioid use disorder diagnosis. And while this study was based on Medicaid claims, we know that despite having private or commercial insurance, the rates of receiving MOUD for young people are extremely low. MOUD is not only underutilized in youth, but buprenorphine prescribing is actually decreasing in this patient population. This paper was recently published in Pediatrics and used IQVIA data to examine buprenorphine dispensing trends among youth 19 years old and younger from 2015 to 2020. Now, IQVIA data contains prescription data from retail pharmacies. So overall, the rate of buprenorphine dispensed to youth decreased by 25% during this period, while dispensing during that same time frame for older adults increased by 47%. Interestingly, buprenorphine dispensing to young women and girls declined by over 50% during the study period, compared with 38% among young men and boys in the same age group. We already know that medication enhances treatment retention in youth. So this data is also coming from Dr. Hadland's group, and it's using Truven Medicaid claims and data in youth ages 13 to 22. And you can see with all three forms of MOUD that treatment retention was increased. So those who received buprenorphine within 3 months of an OUD diagnosis were 42% less likely to drop out of care, 46% with naltrexone, and 68% with methadone. But even with MOUD, treatment retention in youth is lower than in their adult counterparts. So adults or older adults typically have rates of retention between about 40 to 50% each year, or at 1 year. This figure here shows emerging adults, ages 18 to 25, and is versus older adults and rates of dropout at 12 months in outpatient buprenorphine treatment. And in this study, young adults had 57% treatment retention at 12 weeks and 17% at 12 months. Older adults had 78% at 12 weeks and 45% at 12 months. So significantly lower rates. Here's a separate study using retrospective chart review of adolescents and young adults ages 14 to 25. And there was a Kaplan-Meier curve that was fit to describe the patient's retention time over 12 months, which was as low as 9% at that 1 year marker. Again, this is ages 14 to 25. That's incredibly low, with a loss of 25% of patients after that first visit and only 45% retention at 60 days. So I asked myself, what can we do as providers to enhance treatment retention in youth who are receiving MOUD? I'd personally seen patients drop out of care and wasn't really sure about best practices and how to prevent or at least reduce the risk of that from happening. So I first turned to behavioral strategies to see what the effects were of combining therapy and medication in youth. Now, how we interpret the impact of therapy on adults receiving medication with OUD is all a bit murky, likely because of how well medication works and whether or not we are actually measuring the right outcomes. However, the influence of behavioral interventions in youth with OUD hasn't been as extensively studied. There are a few studies looking at both individual treatment as well as group therapies. Some of those are listed here, but it's really a bit hit or miss whether or not medication is included in the treatment plan in these studies. So pertaining to my interest and our shared interest today for this talk, I want to highlight two studies, one in adolescents and the other in young adults. In this first one by Dr. Mark Godley, they compared treatment response to a manualized form of therapy, which was called the Adolescent Community Reinforcement Approach, or ACRA. And the data for this study was collected from patients at over 50 substance use treatment organizations that were participating in a national dissemination project, which was funded by SAMHSA. They looked at adolescents with primary opioid use compared to those who predominantly presented with alcohol or cannabis use who also received the behavioral intervention ACRA. Each group consisted of adolescents who either met DSM-4 criteria, so abuse or dependence in the past year, or reported at least weekly use of that specific substance. This was because sites were not required to ask DSM-4 symptoms by a specific drug, but about 50% did. Instead, the abuse and dependence symptoms, again, DSM-4, were asked for any substance, which is an obvious limitation of these studies. But as a whole, when separate analyses were conducted, youth who reported at least weekly use within these two groups, including the opioid use described, substance use, and other psychosocial problems that were consistent with or even more severe than their counterparts who were diagnosed with abuse or dependence. So again, in this study, everyone was receiving ACRA, and they found across the board, there were no significant differences in initiation, engagement, retention, or satisfaction between the two groups. And initiation criteria was met if participants completed a second treatment study within those first 2 weeks. And for engagement, participants had to receive 2 additional sessions within 30 days of initiation. So that really high risk period of time for potential dropout. Now, this is important because, as we just heard, youth with OUD tend to be very difficult to engage and retain in treatment. And ACRA has strong supporting data for treatment of cannabis use, which was highlighted in the Cannabis Youth Treatment, or CYT study, one of the largest behavioral studies in adolescents with cannabis use. So showing efficacy in patients with primary opioid use that was similar to the response rate for cannabis and alcohol was really positive. Then in a study of young adults, ages 18 to 25, replicating the same adolescent paper from that data set, we looked at similar outcomes of treatment initiation, engagement, retention, and satisfaction. And again, we found no differences between a primary opioid use group compared to the alcohol and the cannabis use group. We also looked at substance use outcomes through 12 months, which I will show you here. So here you see those substance use outcomes through the 12-month period, and they include the percent of days using alcohol, cannabis, opioids, and other drugs by the problem use group. So again, either the primary opioid use group, or OU, or the marijuana alcohol group, or MAU, in these figures. And we found no significant differences between the opioid and cannabis/alcohol groups in alcohol or cannabis use reduction. And it's important to note that many of those who were in the opioid group also heavily used cannabis and alcohol. So that group at baseline was more severe across the board for other psychosocial outcomes. But we used it as a catch-all, meaning if you met the opioid criteria, you were automatically put in that group, despite also meeting criteria for cannabis and alcohol use disorders. So at baseline, participants in both groups reported cannabis use on about 40% of days. And you can see that reduction in the figure B. Opioid and other drug use significantly decreased in figures C and D for the opioid group. And so these findings suggest that ACRA is not only an effective treatment for cannabis and alcohol, but also has potential for opioid use in youth. Now, there were some individuals receiving medication for OUD or MOUD, but that documented number was actually too small. It was about 20 to appropriately analyze in the study. So again, promising results. So for those of you who aren't familiar, what is the Adolescent Community Reinforcement Approach, or ACRA? Well, it's one of the most common manualized forms of treatment in this population, and it has a mixture of modalities, including CBT, MI, family work, and it focuses on increasing pro-social behaviors and decreasing substance use. Some of the procedures include things like relapse prevention, drug refusal, communication skills, sobriety sampling, and a functional analysis of substance use. And you can see here on the right a picture of the actual treatment manual. So here were the original aims of my R21 grant that was funded. For aim 1, does ACRA and buprenorphine increase treatment retention in young adults compared to buprenorphine and limited counseling? And does it reduce opioid use in aim 2, also compared to buprenorphine and limited counseling? So limited counseling was considered a standard medical management session, typically 25 to 30 minutes with a physician once weekly, who also provided some degree of counseling on behavioral change, lifestyle modifications, as well as the buprenorphine prescription. Well, we encountered significant barriers from even the start of this study. We had a terrible time recruiting patients from the community. I was seeing patients with OUD, but they were more often than not wanting extended release naltrexone, and I could not get community referrals for buprenorphine. I was told by multiple therapists, treatment centers, and even detox facilities that they would not refer a young person for maintenance treatment with an opioid agonist. So we ended up moving our study to a multi-site treatment center in Massachusetts, thinking that we would have a better time there. And again, we were unable to meet recruitment numbers. What they noted was not only a declining trend in admissions for OUD, but also overall substance use disorders in youth. And in fact, the agency's adolescent services during this time of the grant were cut in 2019 due to an inability to meet census requirements. So I had to reflect. What had we seen in the literature, and what was I experiencing firsthand? Well, it seemed like nobody really knew how to diagnose OUD in youth, and those that did were sometimes opposed to medication or didn't work in a clinic that offered it. Then the patients that were coming to me already had a preconceived notion about medication, having been through other forms of treatment already. And more often than not, all I could convince them to take was naltrexone. Parents were also concerned about the risk of becoming, in their words, dependent on medication, when their goal was actually to have their child stop taking pills or using heroin. So one can imagine trying to run a buprenorphine study in this environment did not go so well. So NIDA kindly allowed me to modify my aims. And so the first was now to see what was happening across the country for young patients presenting to treatment. I saw firsthand with my grant here in Georgia and then in Massachusetts that patients didn't seem to be presenting to care nearly as often as they had been before. Then the second aim was more focused on potential barriers to MOUD, with a very specific interest in my own state of Georgia. So to begin with these newly revised aims, we performed a secondary data analysis on the treatment episode data set, or TEDS, to analyze trends in admissions, length of stay, and the planned use of MOUD. And for those of you not familiar, TEDS is a repository of patient information and characteristics that are related to substance use disorder, treatment, admissions, and discharges from publicly subsidized, state licensed, or certified SUD treatment facilities. So, in other words, specialty addiction care. These admissions and discharges apply to any level of care, including the outpatient treatment setting. So states collect data on a yearly basis, and it's part of the monitoring of their treatment systems. But note that a significant limitation here is that the question within the TEDS is whether or not MOUD was planned as part of treatment, not actual receipt of treatment. And this question has since been modified in more recent years for the actual use of MOUD in care. Then for part of this aim, we used the National Survey on Drug Use and Health, or NSDUH, to identify both the population prevalence of OUD in youth and their presentation to treatment as compared to older age groups. And using the NSDUH was intentional because it also allowed us to look at the presentation to any type of treatment, including private, not just publicly funded. So a little bit more of a broader landscape. Well, we found that OUD treatment admissions decreased from 2008 to 2017 by 63% for adolescents and by 13% for young adults. And we'll see each one of these items depicted visually here in a moment. About 44% of older adults with OUD received care in the last year that we had data for, which was 2017, compared to 22% of young adults and only 3.6% of adolescents. And when it came to the planned use of MOUD for patients, about 93% of adults had MOUD included in treatment planning versus 56% of young adults and only 2% of adolescents. So here on the left, you see opioid-related admissions for adolescents, and they had a median age of 16, which increased from 2008 to 2010, then decreased from 2010 to 2017. Of the combined period of 08 to 2017, adolescent opioid-related admissions again decreased by overall 63%, and that was from about 10,000 admissions to less than 4,000. Opioid-related admissions for young adults initially increased from 08 to 2011, then decreased through 2017 for a total decline or decrease of 13%, which was about 111,000 to 97,000 admissions. We also specifically looked at heroin, and heroin-related admissions among adolescents declined overall by 39%. But conversely, an overall increase occurred in heroin-related admissions in young adults by about 15%, which was approximately 65 to 75,000. We were also curious to see how these numbers compared to overall treatment admissions for any type of substance use disorder. And so not shown here, but changes in these opioid-related admissions did occur in the context of a decrease in overall substance-related admissions in both adolescents and young adults during the same time, which was about 58% for adolescents and 38% for young adults. So overall SUD admissions decreased nearly 60% for adolescents and nearly 40% for young adults. So a contracture of the treatment system. And I know, Dave, you put in a chat, how much of this is due to closing of treatment centers, due to burdensome regulation, and not enough reimbursement? It is a good question. Certainly some of the treatment centers, as I saw firsthand, are closing, but they're also closing because of low census. So I think that there's probably some burdensome regulations, not enough reimbursement, but I think there's a underdiagnosis, as we'll see here in a moment, of individuals who actually need treatment. So a lot of unexplored barriers to care and just an overall changing landscape that I don't think we fully understand at this point. So here's a striking bar graph representing those differences across both the TEDS and NSDA data. The left panel presents the percent for each age group entering OUD treatment in 2017. Then it's divided by the estimated prevalence of OUD in the community from that 2017 NSDA survey. So we wanted to match it to the last year of data that we had for the TEDS at the time, which was the TEDS 2017 data. Since then, we've had the 2019 released. But the right panel presents the percent for each age group with planned referral to MOUD, and then it's divided by the number admitted to OUD treatment within the TED system. So on the left here, only 3.6% of adolescents with OUD based on population prevalence presented to treatment, compared to 22% of young adults and 45% of older adults. Then once engaged in specialty addiction treatment, only 2% of adolescents were considered for MOUD, compared to 56% of young adults and 93% of older adults. So if that's not an uphill battle, I don't know what is. And the respective odds ratios, comparing the adolescents to young adults, and then the 25 plus age group is in the legend. And all of this was statistically significant. And I can see in the chat, Jose, you put, do you mean that underdiagnosis is growing over time? It's a good question. I think it's hard to tell when we have such low rates in adolescents, 3.6% receiving OUD treatment. Good question. I think it could be a topic for our group discussion at the end to think through a little bit more. So for our next aim, which was published separately, we wanted to know more about the why and what perceptions people actually had about MOUD and how those could differ for each age group. And in this study, we were very specific about defining adolescents as ages 16 to 17, young adults 18 to 25, and older adults 26 plus. And we chose to start at the age of 16 because that coincides with the FDA approval age of buprenorphine. Now, I had a particular interest in knowing what was going on in my local practice area. So we distributed an electronic survey to all licensed addiction treatment facilities in Georgia that were registered with SAMHSA. And the survey had two main sections, including questions that were rated on a Likert scale and then a free response section. And we conducted a series of analyses, and then we qualitatively coded the responses. Now, in this study, it's important to note that participants or stakeholders in the survey were defined as those who we believe influence service delivery, such as counselors, prescribers, assessment intake coordinators, and office staff. We use these stakeholders since often they're the ones that are making the referrals, and they can also either augment or undermine treatment planning for patients, as well as the extent of the use of medication in certain settings. So here on the right is the participant characteristics of the 215 responders, which came from 73 of the 299 treatment agencies that were surveyed. The majority of the participants were 35 to 50, identified as female, had a master's, they functioned as counselors, they served rural communities, and the majority had between 0 to 5 years of experience in the field. We also asked questions about whether or not their agency provided MOUD and in what context. So 27% indicated that their agencies used MOUD for detox, 49% for ongoing maintenance, 6% for pain management, and 26% indicated that their agency did not provide any form of MOUD. Now, participants were significantly less likely to support MOUD in adolescents ages 16 and older, so no big surprise there. But overall, naltrexone XR, or extended release naltrexone, which is that opioid antagonist, was much more favorable than buprenorphine or methadone across all age groups, which is interesting because a recent study demonstrated very poor treatment retention on extended release naltrexone in youth. Although if you take it, it works. It's still really hard to retain patients. Participants also gave us over 1,400 text responses to the 10 free response questions. So people were surprisingly eager to give us feedback on this topic. And they highlighted safety concerns about medication and its potential for misuse, particularly in younger patients. And I think, Dave, you sent something in the chat here. Yeah, let's save that one for the discussion. What we also found in this study was that those who reported receiving formal education about MOUD were significantly more likely to believe in its overall use, its use in adolescence, and to not feel that individuals should fail abstinence-based treatment before being offered MOUD. Here's just a snapshot of some of the questions that use the Likert scales ranging from 1 to 6. We saw significant differences across the board, but it's important to mention as you're interpreting this that the difference in participant attitudes regarding the use of MOUD for the adults versus the young adults, so the 18 to 25, didn't yield noteworthy effect sizes, all of which were less than or equal to 0.2. So those sizes were much higher for the adolescent and the adult comparisons. And you can see some of the participant attitudes and then the differences between the three forms of MOUD, including methadone, buprenorphine, and naltrexone based on age group. We received a total of 1,412 text responses to sort through and qualitatively code. We were very intentional once again to specify for each adolescent question, we were only referring to adolescents ages 16 and older. So this table here lists some of the different themes and sub-themes that we identified in the data. And you can see that the major themes included things like changes over time and the acceptance of MOUD in youth, perspectives, which were more often negative than positive, and then identified barriers to using MOUD, such as family-related issues and a lack of supervision and medication monitoring. And then next to each item is the number of responses that then fit into that sub-theme. So by far, the two that had the most responses within the sub-theme were that MOUD is more acceptable in adults than youth, and that MOUD should only be used in very limited circumstances. Here are a few exemplar quotes from participants, the first of which being, "I don't believe Suboxone should be the first intervention given to an adolescent due to the typically short-term, less than 2 years use of opioids, the severity of their opioid use disorder, and the risk of abuse or long-term dependence on medication. Naltrexone would be a better option for adolescents on a case-by-case basis," which is exactly what I had been hearing from providers in the community earlier on in my study when I was asking them to refer. For our second quote here, "I think medication should be the last resort after other treatment methods have failed with regards to adolescents." So here is a prime example of support for fail first approaches to care. And last but not least, "They will become dependent on those as well, taking that dependency into adulthood. I believe that adolescents need to learn to live as adults in a medication-free environment so they can carry those lessons later on in life. I believe they should only be used for detoxification in young adults and adolescents." So again, really this highlights what I see as more of a paternalistic approach to care that is not supported by the evidence base. we really need more advocacy and education, especially across Georgia. And for the people who have the ability to influence referral for MOUD, not just the prescribers, although there were some prescribers in this study. So who does receive MOUD? Well, again, work from Dr. Hadland has found that younger individuals are less likely to receive medications. Females are less likely than males, as well as non-Hispanic Black and Hispanic youth as compared with non-Hispanic white youth. One study also found that only 1 in 54 Medicaid-enrolled youth receive pharmacotherapy after surviving an overdose when presenting to an ED or an inpatient unit. So incredibly, incredibly low. But my next question was, how does substance use severity influence adolescents receiving treatment? How are we defining who gets medication? Is there a threshold that people have before starting medication? Because we know those with an opioid use disorder don't always receive it, but is there some other arbitrary threshold that people hold before starting medication? So for our most recent study, which is currently under review, the previous ones have been published, we describe patient-level characteristics and substance use symptoms as predictors for MOUD in adolescents, again, receiving specialty SUD treatment. So these are not receiving care in pediatrician offices. These are specialty SUD treatment facilities. And the secondary data analysis used adolescents ages 12 to 17, again, from the TEDS, but this time from 2019, since that's our most recent data available. We then evaluated the relationship between what we determined to be a proxy for the clinical need of MOUD based on high-risk opioid use, which was either reporting daily opioid use over the last 30 days or more, and or current injection opioid use. So they were either injecting opioids or they were using every day. As a clinician, if I saw an adolescent who was using opioids daily for over a month or injecting them, I would absolutely recommend MOUD. First of all, I don't know many adolescents who would meet this criteria and not have an OUD, but even if they didn't have an OUD, I wouldn't say, hey, let's wait and see what other psychosocial and functional problems can occur while we wait and hope that you don't overdose in the meantime. But unfortunately, as we see next, most people don't agree with that approach. So yeah. We then created here a subsample of states that reported having any adolescents who received MOUD in one of their publicly funded treatment sites, which left us a sample of over 1,000 adolescents across the US. Now, it's unclear whether or not these numbers were just not reported in certain states, or if they literally did not use MOUD in adolescents in any of their publicly funded sites. And I'm really hoping it is not the latter. I'm willing to give them a benefit of the doubt, but we can't tell from the data. So then with this sample that we had, this N of over 1,000, we examined the potential influence of treatment history and then these substance use characteristics. For our main finding, we did see a higher rate of MOUD among adolescents who met what we called that high clinical need criteria. So either IV opioid use, current IV opioid use, or daily use for at least 30 days. And while those with the daily use or IV opioid use had significantly higher rates of MOUD, only 1 in 8 individuals meeting this criteria received medication. 1 in 8. The use of MOUD also significantly decreased with education, and we weren't quite sure what to make of this, but previous research has identified higher rates of school dropout and injection drug use in adolescents who are using heroin, as opposed to those with predominant prescription opioid use. And so maybe there's something there contributing to a higher likelihood for MOUD receipt. But long story short, we really aren't quite sure. And I think this is something that needs to be further evaluated. Consistent with other findings in previous research, females in this group were less likely to receive MOUD as compared to males. There were no further associations between age of first opioid use, level of care, whether it be residential or outpatient, referral source, including the criminal justice system, treatment history, and receiving MOUD. So my take home here is that OUD is likely being underdiagnosed. We're not capturing it in adolescents, as seen in some of the TEDS research data, that we are not prescribing as much as we should to youth. And even substance use severity barely serves as a predictor for receiving medication. With only 1 in 8 who are using daily or injecting opioids receiving evidence-based care in our own addiction treatment settings. Again, specialty settings. And then although it's a little controversial, and I would love to open this up to discussion here in a moment, from my perspective, if adolescents aren't receiving medication in these circumstances, either because they don't meet criteria for OUD or it hasn't been appropriately diagnosed, do we need to lower the threshold for recommending medication so that more youth can be considered for treatment? I see Dave in the chat. Yes. Thanks, Dave. So in future analyses, I would advocate that lowering the threshold for prescribing MOUD may be required to capture adolescents who either have OUD, who have not been formally diagnosed, or those at a very pivotal point of their use where they are able to use opioids daily or intravenously without demonstrating the needed functional or psychosocial impairment for an OUD, but still carrying a significant risk of overdose. Then last but not least, we need to not only focus on education for prescribers, but really all stakeholders in addiction treatment, since they're often the ones making referrals, and they can either augment or undermine the treatment planning for patients. So in summary, MOUD is widely underutilized in this age group and remains highly stigmatized. Behavioral treatments are still largely understudied. Again, I didn't even get to study mine. Results support an inclusive approach to barrier and stigma reduction regarding MOUD for key stakeholders working in addiction treatment, not just prescribers. And it's important to emphasize formal and focused continuing education to improve the attitudes and beliefs about MOUD treatment for adolescents and for young adults. So a big thank you to all my collaborators and 2 of my main mentors on this work, Drs. Godley and Dennis. I'm also showing a quick picture of my 2 sons, Pearson Knox, ages 2 and 4. And Knox was actually born in the midst of the JIT documents that I was submitting for this grant. The grant was then funded 2 weeks into my leave, so he was a newborn, and any chance I get, I advocate for flexibility in parental leave for birth or adoption of children for researchers, not just for clinicians,